Okay, we may as well just start now. I'll hand over to Salma so then she can do the first half of the presentation and then I'll go through it, if that's okay.
Hi everyone, my name's Salma and I'm one of the education officers at the ASN. And today this PowerPoint is going to be focusing on neurosurgical interventions for mental health conditions. So starting off with historical context. Next slide, please, Serena. Thank you. So this all started in the early 20th century when psychiatric asylums were severely overcrowded and there was no effective pharmacological treatments yet that existed. And so in 1935, a Portuguese neurologist theorized that mental illnesses like OCD and depression were caused by fixed circuits in the frontal lobes, and he believed that physically severing these connections would allow the brain to reboot. And so this neurologist performed the prefrontal leucotomy, which involved drilling burr holes into the skull and using a leucotome, which is a Y-loop needle. And this basically cored out needles. Sorry, this was used to core out cylinders of white matter from the brain. And Moniz was eventually awarded the Nobel Prize in Physiology or Medicine in 1949. And this served to validate and accelerate the global adoption of psychosurgery. So moving on to lobotomy, a new method was developed after this, which was called the Freeman-Watts method. And in the US, Dr. Walter Freeman and neurosurgeon James Watts refined the leucotomy into the standard lobotomy. And this targeted the prefrontal cortex, as shown in the picture, via the temples. Um, so, seeking a way to treat patients without a sterile operating room or a neurosurgeon, Freeman developed the transorbital lobotomy. And this basically included an instrument resembling an ice pick, which was inserted through the thin bone of the upper eye socket, called the orbital roof. And the needle was then hammered into the brain using a mallet. And once inside, the surgeon would move the tool back and forth to sever these connections between the prefrontal cortex and the rest of the brain, which was a theory previously proposed by the Portuguese neuro scientist. And this actually had a huge impact because Freeman ended up traveling the country in his lobotomobile, and he performed thousands of procedures, often on multiple patients in a single afternoon, using only electroconvulsive shock as a brief form as anesthesia. Next slide, please, Serena. Thank you. However, this was actually very controversial. First of all, something called personality zombification would occur. So while the procedure successfully reduced aggression and agitation in many patients, it came at the cost of the patient's humanity. Many survivors were left apathetic, incontinent, and devoid of complex emotional depth. The second um, the second negative impact of this was that informed consent was violated. So procedures were frequently performed on vulnerable populations, which included children, political dissidents, and the institutionalized. And this was done without their consent. And there was a famous case of a woman called Rosemary Kennedy, which highlighted how the surgery was used to manage difficult family members rather than to treat medical pathology. And third of all was the mortality rate. So the procedure was very physically dangerous, and complications included brain hemorrhages, permanent seizures, and mortality rate, which was estimated between 5 to 14%. However, we have learned from many of the past mistakes made. So, for example, doctors and surgeons have moved from ablation to modulation. Modern interventions such as deep brain stimulation have replaced permanent destruction with reversibility. We now use electrodes to tune circuits rather than completely sever them, which can be turned off or adjusted if side effects occur. Second of all, we have moved from blindness to precision. Lobotomy was a completely blind procedure, and today we utilize stereotactic neurosurgery and real-time MRI guidance to target specific nuclei with millimeter precision and sparring healthy tissue. Third of all is the multidisciplinary safeguard. So, as mentioned before, Freeman would go around the country performing his surgery on thousands of people. However, today, modern psychosurgery requires approval from independent boards consisting of psychiatrists, neurosurgeons, and legal advocates. So, moving on to brain circuits in mental health. Key brain circuits include the cortico-striatothalamocortical loop. So this loop connects the prefrontal cortex, the striatum, and the thalamus, and it's critically involved in obsessive compulsive disorder, also known as OCD. Hyperactivity in this circuit drives repetitive thoughts and behaviors, making it a common target for deep brain stimulation or ablative procedures aimed at reducing these symptoms. The second key circuit is the limbic circuit. This includes the amygdala, the hippocampus, and the medial prefrontal cortex. And this circuit plays a central role in regulating mood and emotions. Dysregulation in this network is linked to depression and anxiety, and interventions that modulate its activity can help improve emotional stability and overall mental well-being. And the final key brain circuit is the prefrontal or motor circuit, and this connects the premotor cortex, the striatum, and the thalamus. And this circuit is associated with motor control and impulse regulation. Overactivity in this pathway can contribute to tics, compulsive movements, and impulsive behaviors, such as those seen in Tourette syndrome. Neurosurgical approaches can target these circuits to reduce abnormal movements while preserving general personality and cognitive function. So how neurosurgery, modulates these circuits. So the first method is deep brain stimulation, and this involves implanting electrodes into specific brain circuits to modulate their activity. And by delivering controlled electrical pulses, DBS can reduce hyperactivity in loops such as the corticostriatal pathway, which can relieve symptoms in conditions like OCD or treatment-resistant depression without permanently damaging the brain tissue. The second one is ablative procedures. Now, ablative surgery selectively destroys small areas of pathological brain circuits, such as targeted lesions in the striatum or thalamus. And this approach disrupts dysfunctional loops and can improve compulsions, tics, or mood symptoms, though it is irreversible and requires careful consideration of risks. Outcomes and considerations. While neurosurgery can provide significant symptom relief, outcomes vary, and these procedures are not cures. Importantly, modern techniques aim to minimize changes to personality and cognition, focusing instead on normalizing the activity of specific neuron circuits. Next slide, please, Serena. So targeted brain circuits enable precise interventions. Modern neurosurgical interventions focus on modulating specific neural circuits by targeting overactive or dysregulated pathways. Procedures like DBS and ablative surgery can reduce symptoms while minimizing effects on personality and cognition. Understanding these circuits is essential not only for effective treatment, but also for ethical decision-making and patient care, ensuring interventions are precise and safe and grounded in neuroscience. Modern neurological interventions. So first of all, starting with DBS. DBS is a neurological procedure that uses implanted electrodes, as mentioned before. And this procedure can be commonly identified as a brain pacemaker, which is similar to a heart pacemaker, as it sends regulated electrical impulses to deep structures, hence the name, to disrupt abnormal signals that could cause things like stiffness and tremors. This procedure is typically carried out in two steps. So the first step involves the neurosurgeon using a stereotactic head frame and precise brain imaging techniques such as MRIs and CT scans, and to precisely guide the electrodes into the brain whilst the patient is awake. Secondly, a pulse generator is implanted under the skin of the chest and connected to the electrodes in the brain via extension wires tunneled under the skin. And unlike other surgeries, this is unique as it is reversible and adjustable since the stimulation can be changed using a controller based on changing symptoms a patient displays. And this system can be shown in the picture in the left-hand corner. So ablative procedures involve the permanent and deliberate destruction of a tiny overactive area of brain tissue to stop faulty electrical signals. Unlike DBS, this method is irreversible and does not involve any implanted hardware like batteries or wires, which means that no follow-up surgeries for battery replacements are needed. This procedure is carried out by inserting a specialized probe through a small burr hole in the skull to reach specific target areas in the brain. And once this target is reached, the surgeon uses radio frequency energy to heat the tip of the probe, creating a precise lesion that blocks the symptoms of the disorder. This is often the preferred choice for patients who cannot have a DBS device due to a high risk of infection or an inability to manage the device's charging and programming. Focused ultrasound is the latest incisionless treatment for movement disorders, meaning it requires no surgery, no skin cuts, and no holes in the skull. It works by using over 1,000 individual ultrasound beams that converge at a single point in the brain to thermally ablate or destroy the overreactive tissue. This procedure is performed while the patient is inside an MRI scanner, and this allows the medical team to see a real-time thermal map of the brain to ensure extreme precision. Because there are no incisions, there is a significantly lower risk of infection or brain hemorrhage compared to traditional surgery methods. Patients often experience immediate relief from tremors during the procedure and can typically return home the same day, though it is generally limited to treating only one side of the body. Thank you, everyone. That's it from me today. Thank you for listening.
Thank you very much, Salma. So, I guess we'll talk about the ethical considerations about using neurosurgery in like these mental health conditions, because obviously over time it has gotten a little more advanced in the fact that it's more focused on what's actually, like the circuits that are actually causing the issue, but it's also now reversible. So it's less damaging compared to the first times and they were being used. So obviously consent is very, very important for almost actually all procedures in medicine, not just neurosurgery and not just for mental health conditions. So obviously consent must be voluntary and completely up to the patient. And it shouldn't have any external pressure from like family, friends, or any like healthcare professionals. So it is our responsibility as future aspiring medics and aspiring surgeons that we make sure that the consent that the patients need is given, like that we need to perform the procedure on them, is completely by them, and that they know like informed decision making, which is the next point. So patients must receive adequate, unbiased, and thorough information about treatment's necessity and purposes and risks, and any alternatives available, because obviously the surgeries you talked about here are ablative surgery and like DBS, they're quite invasive, even though they have improved quite a lot from the other like procedures that like Ignis, for example, invented. So it's much more safer, but there are many other many other treatments that are not as invasive, but obviously these surgical treatments are only used for like really, really extreme cases where medications like antidepressants or other stuff is not working. So patients need to know the side effects, the dangers, and the fact that these are not like cures, these are just they just like help relieve the symptoms. So that should also be part of the patient's consent. Capacity as well. This is a very, very important thing to consider, because obviously patients must be capable of understanding, retaining. Retaining is important, and using the information given to them to make an autonomous decision, meaning that it's their decision and they have like the rights on them. But they can only have that autonomy if they're capable of understanding the pros and cons of the surgery or the procedure they're going to have to undertake. Um, and so, yeah, capacity status must be reevaluated each time before a patient makes a decision between their treatment course. Because obviously, after surgery, you might not have the capacity you need to follow up with other procedures. Because the capacity decreases if the surgery, let's say, wasn't that well performed. So consent can be overridden when a patient you're treating is detained. If you don't know what detained means, it's just when they're a criminal and they're like in custody of the police. Um, a patient is deemed to lack capacity. So if obviously these procedures are performed on really, really severe mental health like conditions, so the patient may not always have the capacity that they need to kind of process what procedure they're going to do. So in that case, when they don't have capacity, then consent is taken from the healthcare professionals to do what is in the best interest of the patient and also family and friends. But that's only if capacity is not like given to the patient. It doesn't, they don't have the capacity. And again, if it's like an emergency, life-threatening condition, such as like, let's say you tr you had a traumatic brain injury, obviously you need to perform the craniotomy as soon as possible. But in terms of these conditions, such as the deep brain stimulation and ablative surgery, it's less likely to be life-threatening compared to if you just got into an accident. Um, so yeah, that is something to consider. And obviously, in some circumstances, again, patients with severe mental health conditions may lack the capacity required. So their treatment may be carried out under the 1983 Mental Health Act, which again, I mentioned this when acting in the best interest of the patient. So this is very, very important. Obviously, consent is dependent on the type of conditions you have. It's very different for every patient. So you need to consider it for all patients that you're treating because you need to be doing what is best for them. Okay, so benefits of psychosurgery is that it provides, obviously now there are many modern and precise surgical techniques that can help to make accurate chart like accurately target specific overactive brain circuits, which may help reduce symptoms of severe OCD or depression or anxiety or anything else. In patients with severe treatment resistant mental health, so this is when you're taking the medications, you're taking antidepressants, you're taking all sorts of pills, but it's not helping. So then neurosurgery for mental disorders, which is also shortened to NMD, has helped significantly reduce symptoms. But this is also because of the fact that we have modern surgical techniques which are trying to be as minimally invasive as possible. So then we don't like damage the healthy tissue because obviously if you damage any tissue in the brain that is important, you can cause language difficulties, you can cause vision difficulties, hearing difficulties, movement difficulties. So it can be very, very invasive and harmful for the patient. So you need to have the modern and precise surgical techniques we're talking about here. And in procedures such as DBS, the system is not permanent and it prevents destruction of brain tissue because again, it's just stimulating that section of the brain. It's not actually removing it or like completely severing it. So it is like you can just take off the pacemaker stuff, and then like the patient will be almost back to normal from before the surgery. So this yeah, so it doesn't need further intervention or surgery. Patients may experience an improved quality of life as neurosurgery um, for mental disorders can help reduce severe anxiety, obsessive habits, and medication dependence. So, like, it will just make the patient's life a little better because they can do stuff without having to take like a bunch of medications that don't even help them. So some risks, obviously, because it's still invasive surgery. Like you're still you know, experimenting with the brain, so it can cause a lot of risks. So, I mean, we already talked about the risks, but brain hemorrhage, strokes, seizures, and infections are quite common as well. Well, not common, but they can happen in terms of like complications during or after surgery. Side effects of NMD may include like temporary or even permanent cognitive decline. So that means they can't do like basic tasks that require cognition. Apathy, which means that they have a lack of disinterest in basically everything in their life. So they don't have many emotions. They're quite emotionless because of the fact that psychosurgery kind of numbs the patient. Um, Speech difficulties or personality changes, because obviously if you're um, changing the brain structure, you're altering the brain circuits, it can have an effect on how you act as a person in terms of personality. And so obviously because this is a like less researched type of field, there aren't many long-term effects that like scientists have discovered yet. But yeah, and NMD is only a management system for symptoms rather than a cure, which I already talked about. It also has varied like outcomes among patients. Some patients have reported little to no change after going undergoing NMD, but some patients have like actually seen improvements in their quality of life, in how they act, and in their personality. And lifelong consultations, so battery management and stimulation adjustments for procedures such as deep brain stimulation raises issues because um, obviously if you're having to go to the hospital for the rest of your life to kind of for stimulation adjustments or battery management, it could raise like issues such as whether all patients are able to access neurosurgery for mental disorders freely due to maintenance costs, because it's quite expensive, obviously, to maintain the DBS. So yeah, now we're gonna look at two case studies about the effects that neurosurgical intervention has had on like mental health conditions. So a survey of all patients who underwent leukotomy in England and Wales from 1942 to 1954. So that's like 12 years. Yeah. Um, so this there documented 10,365 single leukotomy operations, and an additional 762 patients underwent more than one operation. So a follow-up study of about 9,284, so quite a big chunk of the 10,000 that we were kind of like questioning, mentioned patients showed that 41% had recovered or greatly improved, while 28% were minimally improved. 25 showed no change, 2% had become worse, and 4% had died. So obviously this shows that there's a huge variety of outcomes that can come out of these procedures. And not surprisingly, patients with an affective disorder showed the best prognosis, with 63% recovered compared to 30% among schizophrenic patients. So affective disorder may be like depression, anxiety. So they showed better prognosis. Case study two, so psychosurgery in three patients with schizophrenia and refractory aggressiveness. And so this is the 2003 case report. So you could use this in, I guess, your wider reading. You could read about it more. I can send the resources and the PowerPoint into our WhatsApp community if you guys want. So the objective of this study was basically to compare the aggressiveness before and after psychosurgery to kind of see how effective psychosurgery actually is, and if it's actually any good to kind of bring into normal medical practice. So the method was that three patients with schizophrenia and a refractory aggressiveness were selected through a multidisciplinary committee, a committee spelled wrong. Diagnosis was confirmed as well as the type of ablative surgery to be made as well. So the MTT team kind of discussed these patients and the ablative, like the type of ablative surgery was also discussed and kind of planned, like how every surgery and neurosurgery is planned pre-op and then post-op as well. So the results were that the scale of pre-operating objective aggressiveness in three cases had a range between 587 to and 579, and post-operative range between 285 and 253. In case number two, the auditory hallucinations in the patient diminished, for which we do not have an explanation nor references in literature. And so these patients still continue with desires to attack, but no longer carry out, but they no longer carry these acts out after the operation. So basically, I think this is taken from the actual extract from the report. So basically, it's saying that um, they still had the desires, like inside internal desires to kind of attack and act, but they didn't because of I guess so then it did improve. So both procedures had favorable results to diminish the aggressiveness. So again, this is not curing the patients. This is just kind of decreasing, reducing the symptoms. And during the follow-up of patients, they did not require new internations by uncontrolled, and therefore these surgical techniques continue being a valid therapeutic option for the patients who suffer aggressiveness of difficult control resistant to treatment. So this basically what it concludes is that the surgical techniques that we just talked about are quite good at kind of reducing symptoms, but they cannot cure, which is what I've been saying. So yeah, now we're gonna look at like the future aspects of psychosurgery and neurosurgery, neurosurgical intervention in mental health, like uh, disorders. So mental health conditions, sorry. So then using AI to improve like deep brain stimulation is something that neurosurgeons and neuroscientists are looking at because obviously, as we talked about in AI in medicine and AI in neurosurgery, AI can analyze the brain signals in real time and kind of provide fast feedback. And so like in DBS, the stimulation can be adjusted automatically based on patient response, and so there's less likely to be human error. But again, it could be the complete opposite, and the AI might stimulate it too much or too little, and that might not actually do anything to the patient. It might actually cause more harm. So obviously some advantages of that is that it's more personalized to the patient. It can reduce side effects. It's more adaptive in terms of stimulation rather than just constant output. It's like it can adapt as well, and it can potentially have better outcomes in treatment-resistant OCD and depression because it's giving like real-time adjustment to the patient depending on their response. And how it could work is machine learning models detect abnormal brain activity, like brain circuit activity, and then we can kind of train them into thinking, like into doing what like neurosurgeons would do in terms of like what would be the most beneficial. And system predicts optimal stimulation pattern. So then again, the system predicts what would be the best for the patient and continues a continuous optimization over time. Another thing we're looking at, not me, but neurosurgeons are looking at is non-invasive neuromodulation. So this is kind of what altering brain activity without open surgery. So this is very, very non-invasive, and it targets specific neural circuits linked to mood and behavior. So this can be used for conditions such as depression and anxiety, like really, really uncontrolled, like non-medicated depression and anxiety. And so some examples that they're looking to kind of develop are transcranial magnetic stimulation, which is also known as TMS, focused ultrasound. So this is emerging research. We don't have a lot of research on it yet. Advanced external stimulation technologies. And some pros include no craniotomy required. Obviously, this is a major thing because it reduces surgical risk and it can be repeated and adjusted, and it expands access to treatment because not everyone can afford, in terms of finances and also health, to kind of undergo such a invasive surgery such as a craniotomy, because obviously some patients may not actually have the health that requires them to actually have to undertake the a surgery and actually make it out alive. And so limitations include not effective for all patients. So some patients may require a craniotomy and TMS or neuromodulation may not work. Long-term outcomes are still being studied because obviously it's a emerging technology, and ethical and regulatory considerations remain important. So yeah, TMS, just a little more information, is that it's non-invasive procedure that uses magnetic fields to stimulate nerve cells in the brain. And as I said, this is to treat major depression and other mental health conditions. So the electromagnetic coil kind of like stimulates nerve cells in the brain to kind of increase activity and um, like help with the limbic circuit. So yeah, now I'm gonna start with a interactive quiz. So it would be great if we could have like some interaction. It's all like multiple choice this time. So yeah, I'll give you about like 30 seconds. So yeah, modern psychiatric neurosurgery is based on the idea that mental illness, not illness, mental conditions involves A, skull abnormalities, B, hormone imbalance only, C, dysfunctional neural circuits, or D, lack of intelligence. So I'm gonna give you about 30 seconds. Just to answer Alfredo's question, what type of surgeries are these laparoscopic? These are not laparoscopic surgeries. I think laparoscopic surgeries are like where a tube is inserted. But yeah, that is not laparoscopic. It's completely different. It's deep brain stimulation, so that's like where they kind of make an incision into the brain and add the electrode inside and then the pacemaker as well. So yeah, these are not laparoscopic surgeries. Yeah, so we've gotten all C's and that is correct. Uh, just yeah, so that's C. Deep brain stimulation, DBS, is considered a guaranteed cure, B, risk-free, C, a symptom management tool, D, obsolete. Give you like 30 seconds. Yep, exactly. It's C. Why are they all C? Yeah, it's C. Now, ablative procedures involve A, implanting electrodes, B, destroying specific brain tissue, C, magnetic stimulation, and D, behavioral therapy. Yeah, exactly. It's B, destroying specific brain tissue. Now, scenario-based questions. So, a 42-year-old patient has severe depression. They have failed four antidepressants, um, and symptoms remain debilitating. So, they have tried almost all the medications that is required for depression, but it hasn't done anything for the patient. So, what is the most appropriate next step? A, discharge due to non-response. B, consider referral for assessment for DBS. C, immediate lobotomy. And D, increased therapy frequency. I'll give you like 30 seconds. Yeah, exactly. It's B. Obviously for deep brain stimulation and for a lot of medical interventions where surgery is required, we need to kind of assess the patient for like their ability to kind of undergo a surgery because if they have like a lot of I can never pronounce this word, but if they have a lot of like other types of illnesses such as cardiac disease or I don't know, diabetes, then it may affect how the surgeons kind of undergo the procedure. So we need to kind of do the assessment to make their treatment as personalized and as effective for them as possible. So yes, we need to consider referral for assessments. A patient with severe OCD requests neurosurgery but cannot clearly explain the risks or alternatives. What is the key ethical issue here? So A, is it cost? B, surgeon availability. C, capacity to give informed consent, or D, stigma. Stigma basically means like it's quite taboo to get a surgery because of OCD because it's not accepted in society. I think people have already answered in the chat. They're saying C. Yes, that is correct. So obviously, if the patient requires, like they request neurosurgery, but they cannot clearly explain the risks or alternatives or like how the procedure is kind of like undertaken, then they may not have the capacity to give informed consent and they may not have so then you might need to use the Mental Health Act that I talked about in 1983. So yeah, now I'm going to hand over to Neha, who's going to share her screen and talk about sleep and memory and learning in surgical training. So yeah, that is all for neurosurgical interventions.
Can you see my screen?
Yes.
Okay, cool. So, hello, my name is Neha, and today I'm going to be talking about something that most aspiring medics
already sacrifice, which is sleep, and why, from a neuroscience perspective, that may be one of the biggest barriers to becoming a high performing doctor or surgeon. So, why talk about sleep? Medicine and surgery attract driven people, a career with a high workload, high stakes, and high expectations. Long hours are often seen as a badge of honor, but neuroscience tells us that sleep isn't passive rest, it's an active learning process. Most of us intellectually know sleep matters, but behaviorally, we treat it as optional, especially during exams, applications, and clinical training. Sleep is not just rest, it's when the brain decides what information is worth keeping and how efficiently it can be used later. It helps with memory consolidation, skill learning, emotional regulation, and decision making. Learning has three stages: encoding information, consolidating it, and retrieving it under pressure. Sleep is critical for the middle step, which is consolidation. During sleep, particularly deep and REM sleep, the brain literally replays what you learned during the day and transfers it into long-term memory. When you don't have proper sleep, you tend to have poor recall, reduced attention, a slower reaction time, and increased errors. Without sleep, information stays fragile. You might recognize it on a page, but you would struggle to retrieve it in exams or clinical scenarios. Surgery relies heavily on procedural memory, learning sequences of movements. Sleep is essential for strengthening these motor pathways. Sleep deprivation doesn't just affect how tired you feel, it affects fine motor control, judgment, and adaptability, all core surgical skills. As shown in the graph on the left, after prolonged wakefulness, cognitive performance drops dramatically, even if you feel functional. Confidence is not the same as competence. Lack of sleep also increases stress whilst also reducing emotional regulation and empathy, which matter in patient interactions, teamwork, and leadership. Medicine often glorifies sleep deprivation, but neuroscience suggests this culture may actively undermine learning and patient safety. Even before medical school, aspiring medics experience chronic sleep restriction, often at the exact time their brains need sleep to learn most efficiently. And this can be due to many things like exams, applications, comparison to other students, and the fear of falling behind. There's a difference between time spent studying and information retained. Sleep shifts the balance towards learning smarter, not longer. Some evidence-based sleep strategies are shown on the slide, but remember, small consistent behaviors matter more than occasional long sleep. Even modest improvements can significantly improve confidence performance. One of the worst things you can do for memory retrieval is sacrificing sleep right before an exam. And I understand because I'm also guilty of doing the same thing. However, the night before should be about consolidation, not cramming. Over years, chronic sleep deprivation accumulates. Protecting sleep early is an investment in a sustainable surgical career. Sleep is not the opposite of hard work. For surgeons, it's part of training, just like practice and feedback. Now I'm going to play a video where Shai Marku talks about the benefits of good sleep. Are you able to hear the audio, by the way?
No.
Oh, what about now? Let's see.
No, not yet.
How do I do this? Okay, you know what? I don't think I'll be able to play the video, but I will put a link to it. Oh wait, never mind.
I'll play it for you.
Okay, thank you.
Can you hear it?
Yeah.
It's 4 a.m. and the big test is in 8 hours, followed by a piano recital. You've been studying and playing for days, but you still don't feel ready for either. So what can you do? Well, you can drink another cup of coffee and spend the next few hours cramming and practicing. But believe it or not, you might be better off closing the books, putting away the music, and going to sleep. Sleep occupies nearly a third of our lives, but many of us give surprisingly little attention and care to it. This neglect is often the result of a major misunderstanding. Sleep isn't lost time, or just a way to rest when all our important work is done. Instead, it's a critical function, during which your body balances and regulates its vital systems, affecting respiration and regulating everything from circulation to growth and immune response. That's great, but you can worry about all those things after this test, right? Well, not so fast. It turns out that sleep is also crucial for your brain, with a fifth of your body's circulatory blood being channeled to it as you drift off. And what goes on in your brain while you sleep is an intensely active period of restructuring that's crucial for how our memory works. At first glance, our ability to remember things doesn't seem very impressive at all. 19th century psychologist Hermann Ebbinghaus demonstrated that we normally forget 40% of new material within the first 20 minutes, a phenomenon known as the forgetting curve. But this loss can be prevented through memory consolidation, the process by which information is moved from our fleeting short-term memory to our more durable long-term memory. This consolidation occurs with the help of a major part of the brain, known as the hippocampus. Its role in long-term memory formation was demonstrated in the 1950s by Brenda Milner in her research with a patient known as HM. After having his hippocampus removed, HM's ability to form new short-term memories was damaged, but he was able to learn physical tasks through repetition. Due to the removal of his hippocampus, HM's ability to form long-term memories was also damaged. What this case revealed, among other things, was that the hippocampus was specifically involved in the consolidation of long-term declarative memory, such as the facts and concepts you need to remember for that test, rather than procedural memory, such as the finger movements you need to master for that recital. Milner's findings, along with work by Eric Kandel in the 90s, have given us our current model of how this consolidation process works. Sensory data is initially transcribed and temporarily recorded in the neurons as short-term memory. From there, it travels to the hippocampus, which strengthens and enhances the neurons in that cortical area. Thanks to the phenomenon of neuroplasticity, new synaptic buds are formed, allowing new connections between neurons and strengthening the neural network where the information will be returned as long-term memory. So why do we remember some things and not others? Well, there are a few ways to influence the extent and effectiveness of memory retention. For example, memories that are formed in times of heightened feeling or even stress will be better recorded due to the hippocampus's link with emotion. But one of the major factors contributing to memory consolidation is, you guessed it, a good night's sleep. Sleep is composed of 4 stages, the deepest of which are known as slow-wave sleep and rapid eye movement. EEG machines monitoring people during these stages have shown electrical impulses moving between the brainstem, hippocampus, thalamus, and cortex, which serve as relay stations of memory formation. And the different stages of sleep have been shown to help consolidate different types of memories. During the non-REM slow-wave sleep, declarative memory is encoded into a temporary store in the anterior part of the hippocampus. Through a continuing dialogue between the cortex and hippocampus, it is then repeatedly reactivated, driving its gradual redistribution to long-term storage in the cortex. REM sleep, on the other hand, with its similarity to waking brain activity, is associated with the consolidation of procedural memory. So based on the studies, going to sleep 3 hours after memorizing your formulas and 1 hour after practicing your scales would be the most ideal. So hopefully you can see now that skimping on sleep not only harms your long-term health, but actually makes it less likely that you'll retain all that knowledge and practice from the previous night. All of which just goes to affirm the wisdom of the phrase, sleep on it. When you think about all the internal restructuring and forming of new connections that occurs while you slumber, you could even say that proper sleep will have you waking up every morning with a new and improved brain, ready to face the challenges ahead.
Oh, so yeah, I hope that was helpful. I mean, the video was very, very relatable to me because I do not sleep properly. But yeah, I will definitely be trying to do that, and also I would hope that you guys too. Because obviously sleep is quite important for aspiring surgeons and medics as well, because our decisions and how we act is basically we're shaping and forming patients' lives. So we need to make sure that we're sleeping well and that our decisions and our emotions are regulated enough to kind of take care of patients that need our care the most. So yeah, I'm gonna send in the attendance form. Please make sure to fill it if you are interested in getting the certificate for the neurosurgery seminars. We have about 4 left. Please keep in mind though, we have 2 guest speakers coming up in March, so next month. One is going to be an ex-doctor and the other is an orthopedic surgeon. So really, really exciting opportunities to kind of gain insights. Um, but yeah, we're gonna have 4 more lessons on like neurosurgical treatments and procedures. So yeah, that is all we have for you today. We're gonna end a little early as well, so that's bonus. But yeah, please make sure to fill out the form. And if you have any questions, I'll wait around till the end to answer them. I hope you enjoyed this, guys. Bye.